So, how to think like an attending? The first question is actually why you want to think like an attending. And actually, it's pretty simple because if you can think like an attending, you can really stand out during your USCE. That will separate yourself from your other peers, right? Now, I have been an attending for 3.5 years now. I work both outpatient and inpatient settings. This is what I do day in, day out when I see patients. And I'm going to teach you today. There are three things that I'm going to teach you that will elevate your game and make you just like an attending. All right. So the first thing is always consider indication and contraindication, risk and benefit for management. So I'm going to give you an example. Let's say I'm facing a UTI case. It's a simple, straightforward case, right? You may think, oh yeah, the patient have a UTI. I'm going to give an antibiotic, maybe a macrobid. And macrobid is nitrofurantoin, by the way, if you're not familiar with the brand name. So I'm going to just give the macrobid. No, I don't do that. When I see patients with a positive urine, what I see is if the patient actually have indications for taking the antibiotic, is the patient is symptomatic at all, right? Because we don't treat asymptomatic bacteriuria. Maybe we'll treat for pregnant patient, but as an internal medicine doctor, I don't see pregnant patients that often, right? Now, let's say the patient has an indications to take antibiotic. I still don't just jump and then prescribe the antibiotic right away. What I do is I'm gonna look at their labs. I'm gonna make sure they have a good kidney function. I want to make sure that the patient has no allergies. I want to make sure there is no interaction with the patient's medication. So I'm going to look at the list of the patient's medications. And then I'm going to take a look at the previous culture as well. Maybe the patient has recurrent UTI, and I can have the previous culture to direct me what antibiotic I should choose. So I always go through these informations because I need to make sure that there is indication and there is no contraindication. I give the best treatment for a patient that's individualized for this particular patient. I consider all the risks and benefit for everything pretty much. I just give you a simple UTI case, but a lot of things I always consider the risk and benefit, indication, contraindication, whether that diagnostic purpose or management purpose. All right. So that's one key. The second key is to always ask yourself, what else? I always ask myself, what else? What else is possible? So when I receive a sign out from the ED, they say the patient has shortness of breath, the patient has pneumonia. Based on X-ray, we give antibiotics. I don't just go along with the diagnosis. I try to think, what else is possible? Can this patient have PE? Can this patient have congestive heart failure? Can this patient have COPD? And guess what? That happens. There's a completely different frame. The ED provider give me a sign off of patient have pneumonia, give antibiotics, and when I see the patient has like a lot of swelling. The patient have elevated JVP. Patient has crackles. The shortness of breath has been going on for a while. It suddenly get worse. This patient has a CHF, so you don't want to have this anchoring bias. You want to keep to ask yourself, what else? What else is possible? Sometimes I ask myself 2 or 3 times. Like after I got a couple of differential diagnosis that's possible, I keep asking myself, is there anything else? What else? What else is possible? That's really elevate your game because keeping the broad differential diagnosis is very, very important. Right. Now, the third and last one, really going to separate yourself from your peers because when you start as an intern or even sometimes a resident, they often forget to consider these things. And that is to always consider the patient's circumstances. Yes. Now, this is kind of similar, but it's different than the point number one I make. Because the first point, number one, the contraindications, indication, risk, and benefit, is somewhat tested during USMLE, right? So if you've done USMLE step 2 CK or maybe step 3, you see that you have to kind of give the best answer based on the patient's current situation. I'm going to give you an example. The very classic example is gout. When you have gout, you don't just jump to NSAID, right? You have to see if the patient has past medical history, maybe chronic kidney disease, so the patient cannot take NSAID, or the patient's medication list, probably the patient's take Coumadin or other blood thinner, so make NSAID is not a really good choice, so you have to go with colchicine or prednisone. So the UTI thing is pretty much the same. The difference in USMLE and real life is that the USMLE does not give the whole big picture of the patient's circumstances because the patient's circumstances is really what makes every patient really, really unique because every patient does not have the same circumstances, right? So I'm going to give you an example. This is the case that I actually took last night. The patient comes with shortness of breath. Unfortunately, she has a bilateral pulmonary embolism. The patients got heparin, but the question is, what should we discharge the patient with? Well, the typical answer here would be DOACs, right? The direct oral anticoagulants, like the apixaban or rivaroxaban. The brand name for that is Eliquis and Xarelto. But here is the patient's circumstances. Patient does not have a good insurance. Patient is in between insurance and a financial issue because he has been sick for actually quite some time. So at that time, the best answer is not going to be based on the textbook, Eliquis or Xarelto. Probably the best answer for that patient would be Coumadin, because Coumadin is actually very, very cheap. Another possible answer is actually Pradaxa, which is a dabigatran. It could be a choice for the patient, I would say, because dabigatran has a generic. You probably don't know that. I've been attending for 3.5 years, so I know. But basically, you want to consider the patient's circumstances when it comes to management or diagnostic purposes as well. Now, let me give you the 5 basic things that you want to consider related to the patient's circumstances, because when you consider patient circumstances in general, you want to consider the patient's social situation, and these are going to be the 5 social situations that you want to consider every single time when you see patients. By just paying attention to this is really elevate your game, separate yourself from the other peer, and you'll be look like an attending. All right, so these are the 5 patient circumstances you want to consider. First one is the living situations, right? So by simply asking, where do you live? And then the second question is, who do you live with? Right? That's question number 2, the social support or caregiver or disease maker. By asking, where do you live? You know if the patient's living in a nursing home right now, is it from rehab? Is it a skilled nursing facility or assisted living facility, or the patient's coming from home? And who they live with tells you if the patients have some form of social support. Maybe the patient's married. And please note that a lot of people actually in America lives alone. They're estranged by family and such. That is something that I discussed in the first module, right? The third one we want to consider is the functional status, which is the activity of daily living. Can the patient ambulate? Does the patient ambulate with walker, or the patient ambulate with wheelchair or with cane? Who prepares the dishes? Who goes to the groceries? And also you want to consider the patient's cognitive baseline mental status. That tells you if the patient is functional enough to do their daily activity. And then the fourth one is the goals of care. Basically, this is for a patient who is terminally ill, like cancer or bad dementia and such. And then you discuss the goals of care. If the patient is going for comfort care or what's actually happened to this patient, that really affect your management, right? And the last one is the insurance and financial concerns. What insurance does the patient have? Is the patient actually have insurance? And then how's the financial situation is really affect the management. So if you manage to kind of get all these 5 for every patient that you see, and your management will actually change depends on this. Well, but the patients have this, so I think we should do this one instead. They'll be very impressed by you, because you consider the things that other people on the very first year or second year does not consider. But this is what I do day in, day out as attending. I always consider all these 3 things. I consider indication, contraindication, risk and benefit, diagnostic test, and management that I propose. I always keep asking what else, so I don't miss anything. I keep broad differentials. And then I also consider all these 5 patients' circumstances to make sure that my management is individualized and tailored to that particular patient. That's it for the lesson today. I will see you again in the next lesson.